Okay. Thank you so much. Yeah, so dear colleagues, first of all, I would like to start with extending my sincere gratitude, sincere thanks to Professor Yoko Kato and her entire team, to Dr. Bun Seng, to Dr. Krishnan Kuti, to all the brave people who are making this webinar today. And of course, artificial intelligence is a hot topic. It's a major topic of discussion everywhere. And at its core, it's a technology designed to mimic, to imitate intellectual human behavior and to automate tasks normally performed by humans. So this brings us also to the field of medicine, more specifically to neurosurgery. And we're here to explore several key questions. What tasks and problems can AI help us to solve? What are its true capabilities and disadvantages? And very importantly, what are the potential risks and challenges we must consider? So to help answer these questions, we have two speakers today. So the first one is talk by Dr. Gary Sarwin. He'll talk about intraoperative real-time anatomical navigation using machine vision. Dr. Gary Sarwin is a PhD student from Computer Vision Lab from Zurich, Switzerland. And the second topic, it will be presented by Dr. Zolin Wu, more fundamental basic research. Dr. Zolin Wu is a resident in neurosurgery from Tianjin Medical University Hospital from China. And his talk will be devoted to time-resolved transcriptomic dynamics and critical gene lineage profiling from acute to chronic phases of traumatic brain injury. So without further
May I interrupt,
ado,
Professor Kato has joined. You can take
Oh.
her opening remarks as well.
Thank you so much, Professor Kato.
Hi, how are you, Daniel? It seems very wonderful talk, I think. No, sorry, wonderful webinar, I think. Maybe the AI is still a little bit difficult to understand sometimes, but I think it may help the big contribution to the neuropsychiatric treatment, I think, in future. Thank you very much.
Thank you so much, for Professor Kato. Thank you so much for this opportunity, for this webinar to happen today. Thank you, thank you. And today we also have three discussants. Dr. Fyodor Grebenov, a neurosurgeon from Burdenko Neurosurgical Institute, Dr. Mohamed Helmi. I hope he will join us. If not yet, a neurosurgeon from Shanghai, Donglei Brain Hospital from China, and Dr. Rai Kumar, a consultant neurosurgeon from Department of Neurosurgery from Bengaluru, India. So let's get into the business, and please let me pass the microphone to our first speaker, Dr. Gary Sarwin, and the floor is yours, Dr. Sarwin. Please share your screen.
Thank you so much. Let me go ahead with sharing. I guess this is the correct one. Do you see the screen?
Yes.
Awesome. Yeah, hi everyone. Thank you so much for hosting me today. So thank you to Professor Danilev for the very kind invitation. So my name is Gary Sarwin. I'm a second-year PhD student at the Computer Vision Lab at ETH Zurich, and it's very, very nice to be able to present this work to so many clinicians today in the crowd. I will give the talk about intraoperative real-time anatomical guidance using machine vision. To start, I would like to quickly introduce the background information. You're probably very familiar with this, so just briefly cover it. So the main topic is neurosurgery. Obviously, we're dealing with a very delicate environment, and on top of that, navigating this environment is also very challenging. If you're using an endoscope or microscope, you also have a very limited field of view. On top of that, there's low contrast. All the anatomical structures look relatively similar, and then also there's bleeding and flushing, which makes this makes the orientation and navigation of this environment even more complicated. And I'm sure you've seen this countless of times, but I think it becomes quite apparent in these videos. Then from the beginning of neurosurgery, there have been a lot of advancements, and these advancements have always gone very much hand in hand with technological advancements as well. Over time, all these advancements have really pushed the current state of neurosurgery to what it is today, and as well the people involved, of course. And if you look into these technologies, you can basically break them down into two categories. So firstly, by enhancing technical capabilities of a surgeon, so by supporting the ability to perform a desired action of the surgeon, and also secondly, the cognitive aspect. So by providing additional information, it can help in assessing the current situation to plan and define the next actions. Arguably, the cognitive aspect is really the biggest factor that separates, let's say, the possibilities of a surgeon, so that for some procedures, it's very risky for another surgeon and very routine for a different surgeon. And if we can reduce the gap between these cognitive capabilities, we might be able to increase, let's say, surgical quality on a bigger or overall scale. The last addition to the timeline is AI with a question mark, because it hasn't been implemented that much yet, but we've seen already some promising results. And a subfield of that is surgical scene understanding. And these are just two examples. But for example, you can now talk to the surgery using machine vision to understand what's going on in surgery, or you can do segmentations of the surgical tools. And these advancements really inspired us to start with our project ANEAS, in which we aim to provide neurosurgical guidance by analyzing the video from the microscope or endoscope. And there's a couple of reasons why this might be interesting. So first of all, you're really dealing with live information, the current surgical situation. So compared to preoperative MRI, you actually are dealing with the patient and also using the modality that you're actually operating on. So it's relatively intuitive. And if you were able to develop such a system, you can do this at quite low cost, since it's software-based. To provide guidance, overall, there's a couple of questions that you should be able to answer. So it should understand, for example, what the goal of the procedure is, what you're currently seeing, and what the next steps of the surgery would be. And overall, the goal was to go towards a holistic understanding of the surgical scene and the procedure, so that we can provide some guidance by using only the video. And to start with that, we really want to start with the fundamentals, very similar to a surgeon, for example, would start its training by rigorously learning the anatomy. And to do that, we were provided by the Department of Neurosurgery at the University Hospital in Zurich, with two amazing data sets of two different procedures. So we have first a transsphenoidal approach, which we have around 170 videos, 15 anatomical structures labeled in approximately 20,000 labeled frames. And then we have the pterional approach with roughly 80 videos, 7 anatomical structures, and approximately 5,500 labeled frames. And we wanted to see whether we could use the state-of-the-art object detection networks and use them in such an environment. We've already seen some applications, for example, surgical instrument detection, or polyp detection. However, we're not quite sure whether we could just extend this to anatomy detection as well, since we do not have, for example, very nice clear boundaries between instrument and the surrounding environment. And here you can see the results of YOLO version 7, which is the one that we use in this case on the COCO dataset, which is often used as the benchmark. Below you can see our results. You can see that the instrument works quite well as we expected, but also that quite a lot of the anatomical structures are within that ballpark region of the COCO results. And the same is true for the pterional approach. Some of the superficial structures work less good, but the deeper ones that we're actually interested in work quite well, such as the optic nerve and the carotid arteries. And below you can see some visual results. So this is the transphenoidal approach. And you can see that even though there's some flickering, it quite nicely is able to detect the structures at the base of the skull here. So we have the recess and the carotid arteries, for example. And also in the pterional approach, you can see that while this is a very challenging environment, it's still able to recognize the carotid artery and the optic nerve quite nicely. And actually, very recently, we had the opportunity for the first time to try this during a live surgery as well. NVIDIA was so kind to provide us with the hardware to be able to do that. So here, on the bottom right, you can see the box, which is quite small, which is nice if you want to bring it into the OR. And now on the left side, you can see the surgery, and we're very happy to see that it also works in a live setting, which is not very straightforward. So here at the base of the skull, you can see the structures being quite nicely detected again. And in the background, you can see Dr. Carlos Serra performing the surgery in real time. And that was kind of the first step to provide further guidance. And we figured now that we kind of have this understanding of the anatomy, how can we use that to orientate ourselves during such a surgery? So imagine that you're traveling along the surgical path. So from the nasal entry all the way to here to the final destination, you would expect different anatomical structures to appear as you go along. And I can show that in this visualization here. We realize that what you're currently seeing is very heavily correlated with where you are during this surgery. So imagine you're traveling along the surgical path and you would see a structure like the red structure here. Since we're in this tunnel-like structure, you would expect it to increase in size as you move forward or kind of move off to the side as you go deeper and deeper. And if we can figure out how these appearances of the anatomy are arranged along that surgical path, we should be able to localize ourselves based on the current view. So to do that, we take the video frames and we use that detection network that I just showed to get the anatomy that's present. And we take a sequence of those and feed those into an autoencoded structure. So these detections contain the anatomy and where they are located. And we map that onto a one-dimensional surgical path. So this is the one-dimensional latent variable, which actually corresponds to our location on that surgical path. And we have two decoders that tell you how the anatomy is arranged at that location. So you have one that tells you which anatomy is present and one that tells you how it's arranged. And we train this network with this relatively straightforward loss function. That's the cross-entropy loss for the anatomical classes and the L1 loss for the bounding boxes. And I would like to show you what the network was able to learn. So how the anatomy is arranged along that surgical path. So imagine once again that you're traveling from the start to the end. Now the model can show us kind of what it learned of how the anatomy is arranged. And you can see that as you move along, this kind of moves as you would expect, right? It gets closer, like we said, it gets bigger as we move forward, and they're kind of moving off to the side. And for example, the purple one here represents the sphenoid sinus. You can see that as we approach it, it grows bigger. And at some point, once we are passing through the opening, you can see that we discover new anatomy. So the sella floor and the carotid arteries, the recess and the planum, for example. You can also look at this in another way. So now we just look at the anatomy that is supposed to be present at the locations along the surgical path. So on the x-axis here, we have our surgical path, 0 meaning the start, 1 the end. And on the y-axis, we have the anatomy that should be present at these locations. So imagine you have your video and we map it on these locations. You would expect these anatomical classes to be present there and different anatomical structures as you would go deeper, for example. You can also then map an entire surgical video onto that surgical path. So showing how you move through the surgical path as time goes on. So T0 meaning the start of the surgery and T1 meaning the end of the surgery. And you can see that in the beginning, we're moving more in the shallow regions. then as time goes on, we go deeper and deeper. And what's quite interesting is that you can see that in these regions, we spend the most time of the surgery. And if you correspond it to the roadmap kind of that I showed before, this corresponds to locations where we're making incisions. So for example, here, it would be the opening of the sphenoid sinus, and here would be at the base of the skull. So let's take a step back just to get an overview again. So we take the videos, and then based on that, we get the anatomical detections. We can map those onto a surgical path, and then based on that, we can localize ourselves there and anticipate which structures would appear if we were to move backwards or forwards. This was our first work, and I think it quite nicely shows that if we have some kind of anatomical understanding, we can get towards some procedural understanding as well without having any label data regarding the procedure. We did some further work, and for those I will focus mainly on what it was able to do instead of the algorithms for the interest of time. So for the next work, we were interested to see whether we could also give feedback on the camera pose. So as you can see here, the appearance of the anatomy is not always the same. It also depends on how your camera is oriented. And to provide guidance on that, it could potentially support orientation as well. So here on the left side, you can see the model again that we used. And this visualization showed that the anatomy was always in this kind of centered view, which is not always the case, as we just saw in the visualization. So to be able to correct for those rotations of the camera, we added two variables to the latent space, which correspond to the pitch and yaw angle, which kind of represent those deviations from that centered view. And visually, this is what you would get. So on the left side, you can see the surgical video with the anatomy detections. On the right side, you can see the mapping onto a surgical path. So right now you can see that we're at the beginning of the surgery. And as time goes on, we go deeper and deeper. And then in the middle, you have a visualization of how the camera is oriented. So now we'll tell you a bit more, or looking to the right. And later you will see at the base of the skull quite nicely how this arrow follows the orientation or the movement of the camera here. It's important to note that this is all relative, so it cannot really tell you you're looking 10% or 10 degrees upwards, but it can relatively show you whether you're looking in the right direction and whether you should look more or less into that direction, which is probably more intuitive as well than showing exact angles, for example. Then finally, most of the works in this field are focused on assessing the current surgical situation. So what the current surgical phase is, or what you're seeing in the current situation. And we were interested whether we could also provide guidance on what to do next. So anticipating the next movement of the surgical instrument. And the idea would be that we could train an algorithm on some expert surgeons' video database, train it on that, and then use it to assist or train less experienced surgeons. This could easily be distributed because it's software and could potentially increase the accessibility to high quality training. Here's the algorithm that was behind it. It's still very similar to the ones I've shown before. I don't have the time, I think, to go into it, but I'm very happy to answer any questions at a later point. This is an extremely challenging task to solve, but we did get some promising results. So here on the left side, you can see the predictions of where the instrument was going to go. However, we also quickly realized that there's never a single truth in how you should move your instrument. So for another work, instead we used conformal predictions to give you, let's say, more of a region that probably contains the right surgical movement based on statistical guarantees using conformal prediction. And this can give you an idea of what the right direction of movement would be. That's what I wanted to show today. There's still a lot to do, but I think there are some cool takeaways here. So it seems that anatomy can be very good foundation also for machine learning models, using machine vision to get to some kind of procedural understanding. What is nice is that for all these procedural understandings, we don't really use any labeled data. And we think it could be an interesting path towards live guidance and relatively cheap guidance as well. Obviously, we want to incorporate this into more complex scenarios as well. And we might need to integrate it with preoperative information to increase the accuracy. But overall, we think this is already quite nice. And we hope that this is useful also for other researchers. So we published the weights of the detection model for other researchers in the field as well. All of this, of course, came forward out of teamwork. So I'd really like to thank all of the people who have been very dedicated and involved in this project as well. Thank you all so much for your attention, and very happy to answer any questions.
Thank you so much, Dr. Sarwin. Beautiful talk and beautiful technology. And me personally, I have several questions, but I need to give a word to our discussants first. And may I ask Dr. Rai Kumar to say a few words about the talk and maybe discuss it a bit.
Yeah. Hello. Hi, I'm Dr. Raj Kumar from India, neurosurgeon. Thank you very much for this excellent opportunity to converse with you guys. First of all, I'd like to congratulate Gary. It's a very nice and excellent presentation, and the technology that's going to come for us to use in the future, it's very mind-boggling. Thank you so much for helping us through navigating brain, especially when the structures are so deep. And as you told, the contrast is very not clear in the brain structures, especially the color difference. And it's excellent work. And may I know when can it be fully utilized? What about the approvals from the government to use it in the direct surgery, live surgery? And what is your future plan to expand it? Because I'm in India. For us, I don't know when it may reach, but it's a very good tool for us while operating upon brain.
Yeah, thank you so much for the kind words. So I think the approval thing has always come kind of the shadow that's hanging above all of this. So at this stage, it's very much a research project, motivated by seeing, what is possible. Can machines also see the things that expert neurosurgeons see in these images? So far, we haven't touched upon anything, let's say, regarding approval. It's not really a finished product yet.
Yeah, but it will be a great product if properly research done, and if it comes to a neurosurgeon, especially a junior neurosurgeon, as you told, we can learn and predict the probable next best step in the difficult and given situation in each patient. Thank you so much. No more questions. Thank you.
Thank you so much. Dr. Grebenev, would you comment, please?
Yeah, thank you, Dr. Sarwin, for such an interesting report. Without doubt, real-time intraoperative navigation can be extremely valuable tool in neurosurgery. As in my opinion, one particularly important application of this technology is identification of functionally significant regions of the brain during surgery. For example, determining whether a tumor located near the precentral or postcentral gyrus is crucial during the resection in this area. Of course, current neurophysiological methods allow us to localize these regions, but as I think machine vision-based technologies could provide us additional and continuous information about the exact location of these structures. Imagine, for instance, a case of glial tumor located near the precentral gyrus. First, neurosurgeon localizes the precentral gyrus using standard neurophysiological techniques. After that, assistant marks the boundaries of the precentral gyrus for the model. And at the third step, your machine vision-based system could identify the precentral gyrus highlighted in the surgical microscope view and maintain visualization of its boundaries throughout the surgery, even if the brain shifts due to surgical manipulations. Do you think it might be possible to develop such a technology in future? And could it be integrated into the surgical microscope?
Yeah, so let me show you. So at this stage in time, everything is just based on, let's say, the image, right? So it's just the RGB information that is there. So I'm not sure if just using machine vision we are able to extract, let's say, functional information about the brain from these images. So that might be challenging. What, however, I think could be possible is either integrating more novel sensing capabilities into surgical tools and kind of map that onto the 3D space of, let's say, a functional MRI, and then build a correspondence between what you're currently seeing on the endoscope with that 3D information from beforehand. I believe there are microscopes that allow you to overlay, let's say, this augmented reality view onto your microscope so that you can see this information while you're operating.
Thank you. And one more question. Nowadays, when we're talking about machine visual based systems, we're talking about normal structures. For example, optic nerve, internal carotid artery. But what about pathological structures and their details? For example, during removal of arteriovenous malformation, neurosurgeon must accurately distinguish feeders, arteries, and draining veins. And sometimes this is straightforward because the differences of color, of vessel colors. And in some cases, it may be quite challenging. How do you think would it be feasible to develop a model capable of reliably differentiating between these vessels using machine visual based techniques?
Yeah, so that is definitely, I think, also for the neurosurgeons that we work with, a very important topic. So far, the data that we have used only contained labels for, let's say, the healthy tissue. But we're definitely looking into labeling tumor as well. And if there is some, let's say, visual difference between the two using this technology, we do believe that if there's enough data, we should be able to discern the two, so healthy and unhealthy or pathological tissue. But this is a question of time that unfortunately at this stage I cannot answer yet. But yeah, it's something we're definitely interested in also looking towards for sure.
Okay, thank you, Elijah, for your report. Thank you much for your report.
Thank you, Dr. Sarwin. I've got a couple of questions, if you don't mind. And the first one, what about the misclassification rate in your experiments? So what level of accuracy do you achieve, have you achieved so far?
So that is shown here on this slide. This is kind of the more numerical example. So these are the numbers that come forth out of a held out test set. So we have videos that have the labels that are used for training, and then we have videos that have the labels that we didn't see during training. And these are the results on that. This is a combination of not detecting a structure while it's there. It's a combination of wrongly detecting a structure and let's say, it's a penalty for, it's a score that shows you if you detect it correctly, if you detect it wrongly, and also if it's there but you don't detect it. So these numbers are maybe a bit hard to understand just like that, but I think in the videos you can see quite nicely that in a surgical setting, if something is detected wrongly, mostly it's like a very short moment where something appears and then it disappears again. And overall, the right structure is relatively stable. So you can see that sometimes it disappears, sometimes it's not there. But for example, the carotid artery on the left side here is there. And with using the graphical or doing creating, let's say, a more sophisticated user interface, it can also be made less confusing. So you could use tracking over time so that this becomes more stable. Or, for example, if a structure shows up only in 1 out of I don't know, let's say 200 frames that you don't even show it at all. So in theory, I think software-based, we can still figure out whether detection is wrong or made correctly.
Yeah. So the level of misclassification is that you can trust it, so it's not a problem. It's trustable.
So at this stage, I definitely wouldn't operate a patient just by trusting this.
Okay.
But at this stage, it's definitely, I would say, going into a promising direction. So we use quite a lot of labels for this one, so it's around 20,000 labeled frames, and we use neurosurgical residents to label this data, which is quite time intensive. But for example, for the bacterial approach, we have around 5,000 images, which also took a lot of time. But considering this amount of data and already getting some kind of promising results, make us believe that this could be reliable enough in the future.
To be honest, that was my second question. What time did it take you to label 5,000 images?
So for the transformodal approach, this was approximately a 6-month effort, almost full time, I believe. And for the bacterial approach, it took much longer because I can show it here. So as a proof of concept, first we started with these bounding boxes, which is, let's say, relatively fast to label. But then for the bacterial approach, we wanted to achieve high accuracy so that we down the line can do more interesting things with it. And that really took, let's say quite long, more than 6 months, and multiple people working on it as well.
A lot of work. And the very last question, what do you consider the most promising application for that kind of intraoperative anatomy detector? Should it be, for example, for training, for education, or maybe you can use it as a neuronavigator sometime?
Yeah, there were a couple of reasons why we want to start this project. First of all, out of curiosity, like, does this work? Is this possible? Second of all, because of the need of life guidance, right? So most surgeries are based on, I guess the surgeon creates a mental roadmap of the approach, and by looking at the preoperative MRI, and then what the pathology is like. But then once you open the skull, brain shift happens, right? You cannot really look at the 3D map from before anymore. So there's this discrepancy. Of course, you can do, let's say, an intraoperative MRI, but you need to stop the surgery for 1 hour, let's say. Ultrasound is quite nice, but apparently the images are also not very straightforward to interpret, and you need to use additional equipment. So it was quite natural to just use this video, like what the surgeon is seeing, to try to provide some guidance as well. And then this could be used in the, let's say, most obvious case as training, of course. So we had during the live surgery, we had some medical students watching as well, and they found it quite insightful to have the anatomy displayed there as well. But ideally, this would work well enough that you could send it to regions that cannot afford an intraoperative MRI, for example, or all this additional equipment, and just have it running on the screen. Or even for, let's say, emergency cases where a surgeon needs to perform a surgery that he's not very familiar with, to have this kind of guidance behind the scenes to support during those scenarios as well.
Yeah, so you're the early stage of becoming AI-assisted neurosurgeon of future. Yeah.
Let's see.
And I see Dr. Christian Kuti raised his hand for a question.
Yes, just one thing I would like to confirm. First of all, I'd like to congratulate Gary for this wonderful project. It is indeed going to be a game changer if at all it comes out in the near future. But I would just like to say one thing, that this is being devised keeping in the mind to train the young neurosurgeons. So have you considered building in checkpoints at every stage of the surgery, like and transfemoral surgery has a nasal stage, then a sphenoidal stage, and then a cellular stage, and then you go to the pituitary. So have you had built-in checkpoints or even warnings if a surgeon goes astray? I mean, it's not a issue for a proficient surgeon, but for the novice, have you considered building in checkpoints? That is my question.
So we have definitely considered it. It's also a very good question because there has been a lot of work on defining surgical phases and how to be able to recognize them from the video. We still need to figure out what a good way to do this would be, because I think, or what I've heard is that it's not per se the most challenging to figure out what the surgical phase is. The challenging part is figuring out when you have done enough, when you have removed enough tissue to be able to proceed to the next step. And we're not sure yet how to define this in such a setting. One idea would be to define, or how I understood it, is that a next step could be approached as soon as you see certain anatomical structures. So by the appearance of new anatomical structures, so something like this could be done. Yeah, at this stage, we don't have, let's say, a checkpoint list of the things that need to be achieved to get to a certain stage, besides appearance of new structures.
Okay, thank you.
Thank you so much, Dr. Sarwin, and good luck with all your research and your technologies. And now it's time to move to our second talk by Dr. Zolin Wu. Dr. Wu, please start your lecture. Dr. Wu, please switch on your microphone. We cannot hear you.
Okay, thank you. Thank you, Professor Grab. Good afternoon. I'm Zolin Wu from Tianjin, China. It's a great honor to participate in this webinar. I would like to express my gratitude to Professor Kato and Professor Grab for this opportunity, and thanks to Professor Yang for his guidance. I'm pleased to present our recent work, time-reserved transcriptomic study of TBI by combining pathway activity profiling with cross-line integration VM to pinpoint stage-specific genes and define actionable intervention videos across the acute to chronic transition. Our work introduced base-reserved atlas from stage 2 pathway to gene to lineage and reusable pipeline for directional inference and yield candidate target for follow-up validation. This slide shows the high-level rationale of our work. On the left, the thematic shows how transcriptomic combined with bioinformatics converts large-scale sequence data into system-level insights, pathway, and modules that are able to diagnose, and unfortunately, precision therapy structure. The right column highlights recent examples where deep transcriptomic mining, together with machine learning and deep learning and network terminology, has yielded insight and translational leads. This slide shows where time-based gene study are useful. Useful. Top left is stimulus response, how cell change after an environmental shift or a drug over or days. Top right clinical trials track genes change during treatment. Model left development show a slow genes change as tissues grow and differentiate. Together, these examples says one thing: time matters. Mastering genes across time help us under biology and choose one A to treat. This is why we use time resolved. This table summarizes previous time resolved transcriptomic studies across multitude instances from TBI, SCI, development, and gloma spanning different species, time support designs from hours to months, and sampling strategies whole brain specific genes like hippocampus, CA1 or frontal cortex, and even cell type focused data such as astrus. This gap are clear. Many studies cover only part of the timeline across region, limited comparison, and most analysis lack direct mental advance or alignment to clinical phases. So interventional window remain. Our work address these gaps by building a phase reserved stage from pathway to genes to latent to atlas across the full TBI course and applying a testable directional inference pipeline to identify stage-specific triggers and actionable windows. This lab outlines a roadmap for time-resolved transcriptomic with 4 layers. First, processing genes, maps, normalization, and batch correction. Each step feeds back into downstream results. Second, the central produce characterizing temperature dynamics by inferring trajectories that represent changing patterns. Third, to complementary analysis, single gene by gene, modeling to detect dynamic genes and cohort genes to gene approaches that capture coordinate changes, dynamic, static clustering, time course gene set analysis, regularly association networks, and group specific dynamic different networks. Finally, metal varieties for dynamic data direction and network pipelines and intra-platform integration to boost power and responsibilities. This slide shows that TBI is a continuous process. We split it into four phases: acute, 0 to 24 hours; subacute, 1 day to 2 days, to 7 days; subchronic, 2 or 4 weeks; and chronic, more than 1 month. Responses in acute, there is BB break and microglial and microglial inflammation assault. In subacute, complement drives snippets, preening, and reflective abstracts. In subchronic, the brain tries to ruminate and shows snippet plasticity. In chronic, there is axon loss and neurodegeneration. On the right, picture A is an MDS plus place simples in time order. Picture B, the first 8 axons, it has a strong link with time, show step-by-step modeling change. The head map shows peak, plateau to fall pattern to king genes and lineage genes across 4 phases. This slide shows fuzzy C means we use it to find the time-based genes expression modules. We choose FCM because it gives soft memberships, so genes can be in more than one group. It works with many shapes and sites, not only around cluster like Kimis. It is sensitive to noise or lot years. On the right, each small plot shows a cluster time pattern. This thick line is the center pattern, and the thin lines are genes. The lower plot shows membership wise, how strong each genes belong to a cluster. In short, FCM give us a clear time pattern modules. These modules are the base for later steps, combining pathway active and testing the direction or effects. We turn Acute to tronic TBI Transcriptomic into a pathway timeline. We use the tiny progeny to image the pathway activity scores for 14 common signal pathway from genes that respond to perturbation. This timeline shows across the 4 phases: acute, subacute, subtronic, and tronic, which pathway turn on first, which stay on, and which peak late. It moves us beyond single genes results. It helps us find key pathway in each phase and possible driver genes and give support to treatment window, common targets, and what to validate first, because progeny use the weight from attribution data. It reduces space in standard engagement and allows fair composition of pathway activity across the time and symbols, which with phase grouping and correlation analysis. We keep time order signals that hinted at cost. This flow shows we cross the line in generation that links pathway to genes to phases. We use progeny to get pathway activity over the time. FCM to group genes by their time pattern, and WCA to build a call expression modules and a module score for each. We then collect the layer by clarifying pathway scores, FC cluster, and WGCA models with 4 phase. T1 acute to T1 acute to T4 tronic. This build a phase resolve pathway genes map and post to key models, and candidate driver genes help us move from genes list to mechanic and to support actionable time window for therapy. This slide shows we link pathway time patterns and gene models in one simple model. First, we used progeny to get active score for 14 signal pathway for each sample. And next, we use fuzzy C means to group genes by their time pattern and make 6 domainic scores. And we use WGCA to build call expression models, and models core and gene for each. Finally, we able structure equation modeling to connect these layers from layers to pathway to FCM pattern to WGCA model that tests the direction and strength of links. The pathway directs on right to show these links. Box are pathway patterns or models. Arrows show the effects and its size. Thicker lines means stronger effects. With this network, we can quantify phase-specific driver from acute to chronic and choose when and what to target for therapy. This slide shows how function shift across 4 TBI phases and which genes stand out. We first group genes by their time pattern and by co-expression WGCNA, and then link each group to geo function. The eye map on the left shows the cluster over time. The rainbow connect responsive genes to their top functions, and the small plots mark the fixed T1 to T4, where each function is strongest. In T1 acute phase, we use physical transport and hypoxia stress. T2 subacute shows a mix of inflammation and air repair. T3 subtronic catalyze neurogenesis and protein degeneration. T4 tonic is reached for neuron structure. Distal axon. Together, this gave a phase-based map of dominate program and a short list of mark genes for follow-up tests. This slide shows how the 4 time phases from T1 to T2 overlap with our 6 FCM time pattern groups and check the biology behind them. The upset plot on the left counts each overlap, and the dotted rows shows which FCM groups are included. Many large overlaps makes phase, and which means some programs run across the time. The Venn chart show the same idea for the main set. And then the right picture, MDS plot use the SSGSEA Z-score for distal axon and transport vesicle. Each dot is simple. The color is phase and strong score set higher or larger. Both functions appear in several phases, but each phase still tends to match certain FCM pattern. Overall, this intersection and function views support our time-resolved model and help us to see which program persist and which are phase-specific. This slide explains our fine time directionality test and the phase-specific network. We use line up symbols on a fine time grid and background bonus each gene with a step manner cutoff. We build candidate links using string evidence and Pearson if we used. Then test like rules with delay of 0 to 2 steps for both the A to B and B to A. We score the rules accuracy or F1 score and MCC score. Do live one phase to out checks and run permutation test. Next, at the last level, we asked that the previous slot the activity of transport Visco help predict the next score active of B. This distal action we fit a makes a effect logistic model and add bootstrap support. The network on the right, T1 to T2 to T4 top now shows topic each the number below summarize the results. A to B is significant, while B to A is not significant. In short, early visceral activity helps to predict later distal action change. This is very scientific to check robust. This slide compare time series tools. We score each tool for how easy it to understand how well it works with field simples, where it can model direction and find thick and handle non-layer pattern. And what static test it has, that's a typical use. Our method is strong on charity small simple use and direction line. It gives extra p-value and support surface test bootstrap and mixed model. So it works well when sample are fill or uneven, and when you want to route with the A to B or B to A, use the parallel knowledge. First pick our method for clear routes and strong statistics with small simple numbers. Use the other for continuous system models, quick pattern search or rejection across conditions. This slide sum up our three main contributions. First, we built a cross-layer phase resolved atlas at that linker stage to persuade to gene to lineage used FCM, WCA, SEM, and progeny into a testable direct network. Second, we met pathway timelines across T1 to T4 and describe the peak to plateau to fall pattern to find stage specific drivers and actionable treatment window. Third, we provide a reusable pipeline for directions, step manner bring and period correlation score, logged burn rules makes the effect logics rejection model. Bootstrap give a line ear test and a chain of evidence. So I finished my presentation.
Thank you. Thank you so much, Dr. Wu. Very concentrated technical talk. So you need some background in bioinformatics and data science to understand all the details. Nevertheless, we will have a discussion, and I ask again Professor Kumar if he's still here to comment on the talk. Dr. Kumar? Probably he's not online. Okay, Dr. Grebenev, would you kindly say?
Yes, Dr. Wu, thank you for such an insightful report. Traumatic brain injury has long been and continues to be one of the most pressing issues in neurosurgery. A deeper understanding of the genetic mechanisms, biochemical mechanisms underlying traumatic brain injury, as well as dynamics of these processes, could pave the way for the potential solution for many challenges in the field. In your opinion, are there any genetic biomarkers or biochemical biomarkers that could be assessed in patients during routine clinical practice? For instance, could we develop a prognostic model using machine learning to predict the onset of chronic traumatic encephalopathy or other long-term complications based on these genetic or biochemical or other biomarkers?
It's a great question because our model is based on small number of patients. If you want to diagnose chronic traumatic injury brain, we need to extend our patient numbers to improve the model accuracy value. It's very important, and we need to use it in validation in animal model and patient and small size we in hospital patients.
Okay, thank you.
Dr. Wu, as far as I understood, you consider these transcriptomic patterns as correlates with biological phase of traumatic brain injury. Yeah, but do you relate this biomarkers with CT or even MRI data? Because that could be interesting. Are there any structure-specific transcriptomic pattern or transcriptomic? What would be the word? Let's call it pattern. Yeah, that can be predictive of a certain structure damage.
I think it's a different. I think it's a different. I think it's a different diagnosis measure because use the CT, MRI has high accuracy to diagnose the disease, but different patients we need to accord the biomarkers to develop medicine treatment. It's a different treatment way. One is diagnose, another is development medicine.
Okay. Okay, thank you so much. Are there any questions in the audience? I can see any hands raised. So thank you so much, Dr. Wu, and good luck with your future studies. I hope that you'll find a biomarker that can be related to ICP, to TBI acute phases, to maybe some neuroimaging markers or neuroimaging indirect measure from transcriptomic data. I hope so. And good luck. Thank you. Thank you so much. Now we have heard, we have all our program coming to the end. if anyone would say something, comment on the topics, and if anyone have any suggestions or proposals, please. If not, may I ask Professor Kata to say a few words to conclude our session today.
Okay, thank you so much. So the doctor, Gary, and also the Zolin, the lecture was very fruitful and also very wonderful lectures, but maybe a little bit high standard. I think for the next, I think maybe this AI committee session can be useful for the such kinds of the resident or sometimes the medical student. So I think a little bit more fundamental things, then we can have more interest. Of course, I have interest, but such as a daily clinical case, such as a stroke or tumor or trauma. I think another aspect that we need to consider for the next one. Thank you very much for its excellent talks.
Thank you. Thank you so much. Thank you so much, Professor Kata. And we have some proposal for the next AI webinar, so if we can have it maybe in a month or two earlier than 4 months, that would be very good, I suppose, if we have time, of course. Yes. Thank you so much. Thank you, Professor Kata. Thanks to all the speakers and all the audience. And congratulations on our third webinar. So goodbye.
Thank you, Daniel. Bye.
Thank you. Bye-bye.
Arigato.
Arigato.
Thank you, lads. Good.